Okay.
All right, so again, this is going to be a discussion or an overview about symmetric growth restriction. You can go on to the next slide. And by that, we really mean the head size is pretty equal to the abdominal circumference for these fetuses. And like we mentioned last time, really the bulk of the adverse outcome is limited to the bottom 5% of these fetuses. We're using the 10th, below the 10th percentile to define growth restriction, but it's really the bottom 5% that you can see that has the bulk of the adverse outcome. And we talked about how we categorize these as symmetric versus asymmetric based on the head size relative to the body size. And the asymmetry occurs because the fetus has the ability to redirect its blood flow to support brain growth at the expense of body growth. So this is an adaptive mechanism that helps the fetus survive a pregnancy that has placental insufficiency, maintain their own internal health while we're waiting delivery. In symmetric growth restriction, either the fetus is completely normal and just small, or there's a very unusual etiology to the growth restriction. So here in this case, of all these multiple etiologies, we're going to be crossing off twins and all of those things related to maternal or placental causes. So we're really left with questions about genetics, chromosomes, birth defects, and infections. Next slide. And this is just a review again about what we mean when we say asymmetric versus symmetric. So you can see in the symmetric growth restriction, both the head and the abdomen are falling off the growth curve, whereas in asymmetric, it's only the abdomen. The head growth is being preserved because the fetus is redirecting its resources to support normal brain growth. Next slide. So the first thing we do when we diagnose symmetric growth restriction is we do a very detailed anatomic survey of the fetus because there's a strong association between birth defects and growth restriction. Next slide. Approximately 10% of this growth restriction is associated with congenital anomalies. So that's definitely something we need to exclude as a cause. And inversely, 20 to 60% of babies with birth defects will ultimately be found to be growth restricted. This is not a comprehensive list, but some of the more common birth defects we see are omphalocele, gastroschisis, diaphragmatic hernias, skeletal dysplasias, and some congenital heart anomalies. In those first two, we know that the abdominal circumference is going to be affected by the actual defects, and sometimes we'll exclude that as part of the biometry. There should be a fetal echocardiogram performed if there's any concern at all about cardiac development. Next slide. So ventricular septal defects and atrial septal defects are the most common heart defects. So this is something we scrutinize carefully, looking for any evidence of that. And certainly perimembranous VSDs are strongly associated with chromosome disorders, in particular Down syndrome. Next slide. So reviewing the genetics of the fetus is important. This has been made very much more approachable and acceptable to patients by the advent of cell-free DNA screening. So just with a maternal blood test, we often can get the answer. In a smaller percentage of cases, we're going to do more of a deeper dive into testing the fetus directly. Next slide. So candidates for genetic studies, this would include fetal growth restriction that occurs before 32 weeks in the absence of an identifiable non-genetic cause. or fetal growth restriction with a major structural abnormality identified, or so-called soft markers of aneuploidy. And then also growth restriction that occurs coincident with increases in amniotic fluid volume. These can be strongly associated with genetic abnormalities. Next slide. So we go about this through a variety of testing modalities. As I mentioned, the most approachable is to simply get a cell-free DNA test from maternal blood. It's non-invasive, but should, at least as of today, should be considered non-diagnostic. It's still viewed as a screening test, but it often will give you the answer up front. In other cases, we might choose to do a microarray assessment or a conventional karyotype of the fetus. This requires an invasive procedure like amniocentesis, can be done off of the placental biopsy or chorionic villus sampling. There clearly microarray can improve your diagnostic yield over a simple karyotype. So for example, this was found to be true in 4% of non-anomalous fetuses with growth restriction, but up to 10% in fetuses who were growth restricted who also had anomalies. Still sort of considered experimental, highly labor intensive is whole genome sequencing, which seems to offer a very incremental small yield beyond a microarray, but can be informative in select cases of things like skeletal dysplasia. Next slide. So this is just a graph that sort of illustrates the compounding risk of when you see birth defects combined with polyhydramnios. So growth restriction as a whole can have up to 70% aneuploid fetuses. If you add in structural defects, that increases it to almost a third. Polyhydramnios without anomalies, 27%. Combine the two together and almost half of the fetuses will be aneuploid. Next slide. Next, we're going to shift and just talk about fetal infection. So this is a fairly comprehensive list of known fetal infections that can be acquired through the mother in pregnancy: rubella, CMV, varicella, toxoplasmosis, HIV, malaria, Zika virus, and COVID, question mark. So when we're doing an ultrasound on these growth restricted fetuses looking for evidence of infection, these are the things that we might see: enlargement of the lateral ventricles, small head size, calcifications within the brain, this periventricular leukomalacia we were referring to, heart failure, cardiomegaly, hepatosplenomegaly, calcifications in the liver or the fetal bowel, fluid in the chest or around the heart, frank fetal hydrops with or without skin edema, and then thickening and enlargement of the placenta. So these are just a couple of slides to demonstrate that finding. On the left, you see a thickened placenta. On the right, you see calcifications within the placenta. You see decreased amniotic fluid or polyhydramnios in frame D. Frame C, like in our case, had cardiomegaly and pericardial effusions. And then in frame D, you see a small amount of fluid within the abdomen or ascites. And then again, at the last slide, you see that periventricular infiltrate in a CMV infected fetus. Next slide. So if we become suspicious and we want to pursue a diagnostic test, there are two things we can consider. One is to draw maternal blood to look at antibody production. So this just graphically shows how initially we produce IgM antibodies, and then after usually about 3 weeks, we'll begin to produce IgG antibodies. So this can not only help make the diagnosis of something like a CMV infection, it can also help you time the infection to determine whether or not the fetus is at risk. Some infections occur so early that we know the mother has already developed an immunity and the fetus will not be affected. So the timing of the infection can be very helpful in counseling the patient. And then to absolutely confirm whether there's still virus present, we can do an amniocentesis test for the infectious agent within the amniotic fluid. Next slide. And just to end the discussion, there can certainly be cases where maternal nutrition can impair fetal growth. But suffice it to say, this really has to be almost at an extreme level, almost at a famine level. And we know this by sort of 2 observational studies. One was done during the period in World War II known as the Leningrad siege, where there was extremely limited nutritional resources. And just looking at births that occurred during that multi-year period, there was on average about a pound reduction in birth weight. A different situation occurred in Holland where there was only about a 6-month famine. And there they were able to look at impacts of malnutrition at each trimester. And of interest, it only seemed like the 3rd trimester was the truly vulnerable period of fetal development that resulted in a decrease in birth weight. Next slide. Rare, but other things that can sometimes affect fetal growth, a relative lack of oxygen that you see with people living at extremely high elevations. So for example, a place like Leadville, Colorado may result in on average, about a 250-gram decrease in birth weight compared to people living at sea level. Certainly cigarette smoking is a known factor that can affect fetal growth. Other substance uses like alcohol, heroin, or cocaine, and then sometimes prescribed drugs, carbamazepine, hydantoin, gabapentin, and beta blockers are famous for being associated with growth restriction. Next slide. So what do we do once we've identified these cases? We start twice weekly fetal reassurance testing, sometimes even more often if it's severe, extreme prematurity, and we're trying to eke out every day of the pregnancy that we can. Sometimes we'll even admit patients to the hospital and monitor them daily or continuously. It's important to look at the amniotic fluid volume once a week because there's a strong association with oligohydramnios. We scan them again about every 3 weeks. It takes almost that much amount of time before you can meaningfully interpret changes in fetal measurements. If their fetal weight is between 3 and 10%, then we're targeting delivery at 39 weeks. If they're in the bottom 3%, then 37 weeks for delivery. We certainly give steroids liberally if there's the potential for a preterm delivery. And then there's controversy about treating infection. We'll usually offer it for CMV, but the literature is sort of mixed on whether or not the treatments we have are efficacious or not. And I think that's the end of that talk. So we'll certainly open it up again for any